So our next speaker is Nevena Damjanov. I apologize. She's an associate professor in medicine at the University of Pennsylvania, where she's also the director of GI oncology and clinical research. She is originally from Yugoslavia, now Croatia, so Dayton has a very special place in her heart. Actually, the first thing she asked her is like, where can I get some postcards? This is a huge deal for me to be here. She attended Drexel University College of Medicine and completed her residency in internal medicine at Penn State University. She went on to complete her fellowship in hematology and oncology at University of Pennsylvania Hospitals. Dr. Damjanov.
So I will tell you how I pronounce it and how my parents pronounce it, but I will answer to anything, and in Philadelphia, I also answer to yo. So, yo. So I pronounce it Nevena Damjanov, but again, whatever you want to call it, I know who you mean, I'm good with that. I'm a medical oncologist, and I'm actually pleased to have more than 5 people in the audience. Usually when they say, and now the medical oncologist will speak, there's just a massive exodus because, of course, the one thing everyone wants to do is avoid the medical oncologist. So in my talk, what I will do is I will remind you of ways to avoid me, which some of my colleagues have already reviewed. Then I will tell you a little bit about how I give chemotherapy in patients who don't have clinical evidence of cancer, what's called the neoadjuvant or the adjuvant setting. And then I will tell you about palliative chemotherapy, which is chemotherapy meant to allow patients to live longer and better. Colorectal, the epidemiology, to remind you, this is a big deal for us. It's the 3rd most common cancer diagnosis in the United States. So it's a lot of people get colon cancer. In 2015, over 132,000 of people had colorectal cancer. It's a 1-to-1 male to female ratio, so as many men as women get cancer of the colon and the rectum. It's the 2nd leading cause of cancer deaths in men and women. That's a lot, right? Lung cancer is still number 1. And even though there are more prostate and breast cancers diagnosed, thankfully a lot of people don't die from their breast and prostate cancer diagnosis. There's a steady decrease in age-adjusted incidence and death rates of colorectal cancer over the last 20 years, and we're not always certain that we actually know what is going on here. This is from the New England Journal of Medicine article, so big people have noticed that patients are dying less of colorectal cancer, and there is a reduced incidence of both local, meaning just in the colon, regional, meaning spread to the lymph nodes, as well as metastatic. So for the metastatic, on behalf of my medical oncology colleagues, will take some kudos for that. But the local and regional, we really don't know exactly what is going on. We do know that there's an increasing incidence of colon and rectal cancer after the age of 60 and after 50, so we start screening 10 years before the increase in the incidence. That's where the thinking is, you'd go from adenoma, a good colon cancer starts in a polyp, and over the course of 10 years progresses to cancer, and if you can catch it before it turns into cancer, you will be cured of the cancer before it becomes a problem. So, in the US, there's a rising incidence in the right side of proximal colon cancer. As you heard from our first speaker, that's not actually an increase in number, but rather an increase in percent. So the higher percent of patients are getting right-sided colon cancer, probably because we're getting rid of left-sided colon cancers better. It may be related to improvements in diagnosis and treatment, increased screening, so screening is good for you, removal of adenomatous polyps in the distal colon, distal meaning close to the rectum, accessible by the sigmoidoscope, and the colonoscopy is more effective in preventing left-sided colon cancer. The difference may be due to the quality of the colonoscopy, poor right-sided prep, so if someone ate lentils when they shouldn't have eaten lentils, it may be a problem because there'll be floating lentils in the right side of the colon, and incomplete colonoscopy due to the tortuosity of the colon, anatomic configurations. And the biology does differ between right and left colon cancers. The right has more serrated adenomas, the flat polyps. They're difficult to find, more difficult to visualize. They carry the BRAF V600E mutations, and those kind of strike fear in the heart of medical oncologists. They tend to be more aggressive, they tend to be less responsive to chemotherapy, and they tend not to respond to epidermal growth factor receptor antibodies. Also, the right side has more microsatellite unstable cancers, which is also not a good thing. We're, of course, assuming that if you remove the premalignant adenomas, you can prevent colon cancer, that you remove localized colon cancer may prevent colorectal cancer-related death. We assume that colorectal cancer is infrequent in those under the age of 40. Of course, you can tell my 30 and 20-year-old patients with metastatic cancer that as much as you wish. It is unfortunately underdiagnosed in those patients at an early stage. So frequently, young people under 40 who have colorectal cancer will not be taken seriously by their primary care providers. And unfortunately, those patients will go on to get more aggressive, more advanced cancer, which unfortunately may lead to their demise. So, lifetime incidence of patients at average risk is 5%, so the vast majority of us will not have colon cancer, and 90% of those cases occur after the age of 50. Progression from adenoma to carcinoma, those are the well-behaved colon cancers, takes at least 10 years on average. 2/3 of the polyps are adenomas, the precancerous ones, and the villous adenomas are the greater risk for colorectal cancer than tubular adenomas. And non-polypoid flat adenomas account for only 20 to 36% of adenomas. Those are the flat ones, the hard to detect. In general, I remind patients that just like mammography is not perfect in detecting breast cancer, colorectal cancer is not also perfectly detected with colonoscopy. Colonoscopies are about 95% effective in identifying cancer. You can have cancer and have a colonoscopy and not know it. Who has elevated risk of colorectal cancer? These are patients who should be screened more frequently. You heard about Lynch syndrome. It's only 2 to 3% of colorectal cancer, so it's a small percentage of patients. Those patients also have a higher risk of endometrial, stomach, ovarian, pancreas, uterine, kidney, biliary tract, and brain cancers. So for me, it's very important to know if a patient of mine who has otherwise insignificant comorbidities has Lynch syndrome. For that reason, most academic centers, the pathologists automatically, as soon as they know that they have a case of colorectal cancer, will do mismatch repair protein testing or microsatellite instability testing looking for Lynch syndrome, even if the patient does not have any family, because that person has a higher risk of developing other cancers. There's FAP, which you heard about. 100% of people develop colorectal cancer, usually before the age of 50. 100%, that's kind of hard to argue with. The patients who have had previous colorectal cancer or previous polyps. We know your colon can make colon cancer. We know they can make polyps. You need to be screened more frequently. They have 1.4 times the rate in the general population, so it's not like it's guaranteed that you'll get another colon cancer, but we don't want to take the risk. You heard about inflammatory bowel disease, previous abdominal radiation, especially for pediatric tumors. That increases your risk of getting colorectal cancer. Radiotherapy for prostate cancer, I'm sure you'll hear a little bit about that. Those patients have 1.7 times the rate of rectal cancer than the general population. So radiation, therapeutic radiation, increases your risk of cancer in whatever organ was irradiated. HIV-infected males have a higher risk. And obesity. Another reason to stay away from that yummy Chex Mix that I was enjoying just now. This is also from the New England Journal of Medicine, published very recently. And colon cancer is, you can see here, I try to emphasize it right here. It's not as high as esophageal adenocarcinoma or the risk of cancer of the gastric cardia, but it is still 1.3 times the risk of a patient with a normal BMI. So yet another reason why we should try to maintain a weight in the normal range. Screening for colorectal cancer important because we've demonstrated, as you've seen from the first talk, this survival improvement in randomized trials. So guaiac-based fecal occult blood testing, 32% reduction in death, not just diagnosis, but in death. Flexible sigmoidoscopy, 23% decrease in the incidence of colorectal cancer. When I was a little resident, they actually tried to teach me how to do flexible sigmoidoscopies because they thought primary care physicians should be able to do that. I don't think they do that anymore. I think they've learned their lesson probably from me. But nonetheless, if you cannot get past the descending colon, there is a benefit to that as well. The recommended screening tools, which was reviewed earlier, from age 50 to 75, fecal occult blood testing, flexible sigmoidoscopy, and colonoscopy. And that's not the CT colonoscopy, but rather regular colonoscopy. Other tests that are out there, remember, our goal is to avoid me, right? So whatever you can do to prevent colon cancer from taking a person's life is good. If you can get a colonoscopy, that's the best. But Cologuard is actually indicated for people who are 50 or older who are at average risk for colon cancer. So not people who've had previous polyps, who've had previous cancers, who come from a strong family history, but at average risk, those who have a 5% risk of developing colorectal cancer in their lifetimes. It's non-invasive, looks at stool DNA. Its sensitivity was 92.3%. For colon cancer and advanced adenomas, so precancerous polyps, 42.4%. That was compared to the one-time, so not repeated, but one-time use of the fecal immunochemical test for hemoglobin that had a sensitivity of 73.8% and 23.8% for adenomas. However, roughly 10% of the cohort had a positive stool DNA result and entirely negative results on colonoscopy, so false positive. 1 in 10 false positive rate is nothing to sneeze at either. And then, of course, this is what my patients want. Why can't you do that school blood test for screening for colon cancer? Why do I have to go through the colonoscopy prep? Well, there is the EpiPro-Colon that has been approved by the FDA. It's blood-based colorectal screening test. It's fast, easy, it's non-invasive. We talked about the Septin-9. I will have to actually look in the article to see what other malignancies secrete Septin-9. But it's definitely increased in patients with colorectal cancer. It's found in the tumor DNA of the colorectal cancer and is shed into the bloodstream. It's been available in Europe since 2012. And you can see these are 2 studies. There were actually 3 studies that the FDA considered. The sensitivity, so looking for colon cancer, was 68.2%, specificity 80%, negative predictive value 99.7%, that's pretty good, but the positive predictive value was only 2.4%. And in the second study, you can see that it was statistically non-inferior to FIT with respect to sensitivity. However, it was statistically inferior for specificity, and you can see the specificity there. So, who gets to have the blood test for colorectal cancer? No one who can be convinced to get a colonoscopy, right? So colonoscopy is first, number 1, 2, 3, 4, 5, down to 20. It's not meant to replace any of the better tests that are available now, and this is the FDA's decision. It's primarily meant for people who have declined other types of screening. Right. So if they said absolutely no way, no how, are you doing anything that's recommended, you can say, okay, well, fine, let's do this test. Better than nothing. But that's basically all you can say, it's better than nothing. It has not been shown to reduce mortality from colon cancer, unlike the other tests. It may, I should have put that in bold letters, may help reach the colorectal screening target in healthy people 2020 of 70.5%. 2008 baseline was 52.1%, so better than nothing. The positive test results, the false positives, have been observed in clinically diagnosed patients. So you increase the blood pressure and increase the anxiety rate of people with chronic gastritis, so people who have just inflammation of their stomach, lung cancer, and also in pregnant women. Colonoscopy is the way to go. Lynch syndrome. Again, very important from my end, trying to identify people who are at risk not just for additional colon cancer, but also other malignancies. Here's but a more thorough list. It's also known as hereditary non-polyposis colon cancer, HNPCC. That's why we call it Lynch syndrome. It's easier to pronounce. It's a hereditary disorder. It's caused by a mutation in the mismatch repair gene. Affected individuals have a higher than normal chance of developing a whole slew of other malignancies that are listed here. The American Society of Clinical Oncology recommends tumor testing for Lynch syndrome in all patients with colorectal cancer. It used to be that the recommendations were only for patients who had developed colon cancer before the age of 40. Now it's for basically, if it's colon cancer, check it for mismatch repair protein or microsatellite instability. Alternatively, for those who are older than 70 and meet any of the revised Bethesda guidelines, the Bethesda guidelines tell us how to diagnose Lynch syndrome, is if you develop colorectal cancer under 50, if you have colorectal cancer and other cancers linked with the Lynch syndrome, so if you develop uterine cancer before your colon cancer, develop colorectal cancer with tumors features linked to Lynch syndrome at an age younger than 60, and colorectal cancer in one or more first-degree relative who also has had Lynch syndrome-related cancer, and two or more first or second-degree relatives with another Lynch syndrome-related cancer. So there are many reasons. So it's easier, instead of trying to remember all of these, it's just easier to ask the pathologist to do mismatch repair protein testing or PCR for MSI. So why do we care? Well, I told you, for me, it's important because patients with Lynch syndrome can get other cancers, and I certainly want to be monitoring for those patients if they have been cured of their colorectal cancer. But in addition, it can give me some information, especially if the patient had a resected stage 2, so local, has not spread to the lymph nodes, colon cancer. In patients who have either mismatch repair protein deficient tumors or microsatellite instability, MSI high tumors, and have stage 2 colon cancer, their risk of recurrence is so low that we would never recommend postoperative chemotherapy to reduce the risk of recurrence. So in stage 2 patients whose cancer has not spread to the lymph nodes, Lynch syndrome is a good prognostic indicator. What else do we know about colorectal cancer? Well, the presentation and diagnosis, because of the increased risk of screening, fortunately, the vast majority of patients do not present with metastatic disease. 76%, so 3/4 of the patients, present with early stage disease. 40% with tumors that are localized to the colon and the rectum, 36 with regional disease, meaning spread to the lymph nodes. Only 20% present with distant metastases. However, as was noted before, 50% of those patients will develop liver metastases at some point in their tumor course. Rectal cancer tends to metastasize to the lung first. Colon cancer tends to metastasize to the liver first, and that's due to the lymphatic drainage in the body. The 5-year survival rate for patients diagnosed with distant metastases in 2016 is about 11%, which is better than the 0% a few years back, but it's certainly not something that we're happy about or screaming from the rooftops. Systemic therapy, that's chemotherapy for all of you, but systemic therapy, this is how I make my living. There's not much out there for colon and colorectal cancer. 5-fluorouracil was developed a long time ago, before I was born, and for the longest time, most of my lifetime, it was the only game in town. And we learned how to give 5-FU this way, 5-FU that way, 5-FU daily, 5-FU weekly, 5-FU by continuous infusion, intrahepatic. It was 5-FU for colon cancer. Nothing else had been shown to be effective prior to 1998 when irinotecan was developed. After that, in 2001, capecitabine was developed. Capecitabine, or Xeloda, is the oral medication that is transformed into 5-FU in the liver. So capecitabine is chemotherapy, even though it's a pill, and it's a horse pill at that. So when I say, somebody says, I want chemotherapy for my colon cancer, they need to know what they're actually asking for. Oxaliplatin is another chemotherapy that was developed in this century. It tends not to be very effective on its own. It really helps if it's added with 5-fluorouracil, so we won't give it as a single agent, but we'll give it with 5-FU. Cetuximab is an anti-EGFR antibody. That's the one that got Martha Stewart into trouble. Do you remember? So Martha Stewart made two mistakes. One was she sold her stock based on insider trading, which is a no-no, because the first clinical trial for cetuximab was not positive. And then, of course, the second mistake was she sold her stock of a medication that then became FDA approved, and she could have made much more money. And then she ended up in jail for the first offense, not the second one. Bevacizumab is also known as Avastin. It's an anti-VEGF. Panitumumab is Vectibix, which is another anti-EGFR. Regorafenib is Stivarga, another pill that can kind of make your hands and feet not very happy. But it keeps people alive longer. Zivaflibercept is a VEGF trap. VEGF trap, very similar activity to bevacizumab. Trifluridine tipiracil. I go to cancer doctor school to be able to pronounce these. Is also known as Lonsurf, which is easier to pronounce. It's also a pill. And ramucirumab has been approved in also another anti-VEGF, anti-VEGF2, has been approved for other tumors as well as colorectal cancer. So it sounds like there's a lot of agents out there, but a lot of them have very similar mechanisms of action, and really it's less than we would like. Adjuvant therapy. Adjuvant therapy is chemotherapy administered after potentially curative surgery in hopes of getting rid of micrometastases, so cells that we cannot see, but we know have a high likelihood of being in the liver, in the lung, in the lymph nodes, someplace where the surgeon just didn't know that they were there to remove them. Our chemotherapy is good enough to kill solitary cells with curative intent. It's not so good at getting rid of this, and this is cancer of the colon we're talking about, not other cancers. It's not so good about getting rid of cancers that are visible to either the naked eye or radiographically. This is staging of colon cancer, colorectal cancer. It changes every few years. This is this year's version. Basically, localized disease is in the colon. Stage 1 is less deep than stage 2. Once it goes to the lymph nodes, it's stage 3. Once it leaves the area where it started from, so it goes to distant lymph nodes, the lung, the liver, it's stage 4. Piece of cake. But it does change from year to year. The idea of staging is to predict the likelihood of death. And periodically they change because these epidemiology changes a little bit. Adjuvant therapy, so treatment with chemotherapy, is meant to benefit more than harm. So in stage 1 colorectal cancer, the likelihood of recurrence is so low that adding 6 months of chemotherapy is not beneficial for the population at large. Stage 2, the likelihood of recurrence is high enough to consider it in some patients. And for stage 3, the likelihood of recurrent cancer is over 50%, so we consider that a good enough reason to treat everybody. Here is the brief history of adjuvant therapy of colon cancer. We talked about why 6 months. Well, this is why. In 1990, before 1990, we didn't actually know that chemotherapy helped people with resected colon cancer. In 1995, if you and levamisole is an antihelminthic, kills worms, in pill form. We gave that for a whole year. So 5-FU and levamisole was better than surgery alone. So surgery with chemotherapy is better. Patients live longer than with surgery alone. 5-FU and leucovorin, which is a vitamin, much more pleasant than an antihelminthic, is better than surgery alone. 5-FU leucovorin was shown to be better than 5-FU and levamisole. But when I did my training, all my patients got 5-FU and levamisole for a year. It was only in 1998 that they showed that treating for a year after surgery was no better than treating for 6 months. And that same year, they found that levamisole, since most of our patients don't have worms, was unnecessary. High-dose leucovorin is just as good as low-dose leucovorin. High-dose leucovorin is 500 milligrams per meter squared. Low-dose is 200 milligrams per meter squared. Weekly, meaning that's also called the Roswell-Park regimen, 6 weeks on, 2 weeks off, once a week through a peripheral IV, is just as good as the Mayo regimen, which is 5 days in a row, every 28 days. As my mentor, Dr. Dan Heller, would say, one of the things we learn is you must hold the Mayo. So that is, we do not give the Mayo regimen anymore. And LV5-5-FU, also known as the AO or German regimen, is equivalent to the monthly bolus. So Roswell Park became the de facto standard regimen for patients following surgery. Of course, nowadays, we went one step better. Folfox is recommended for early stage colon cancer, stage 3 definitely, stage 2 maybe. Irinotecan, so FOLFIRI, IFL, any of those, has been shown not to be beneficial in multiple trials. Capecitabine, that's the pill, the Xeloda, is active as a single agent and is as good as Roswell Park, maybe a little bit better. Continuous infusion, that's the AIO regimen of 5-FU, is less toxic and as effective as 5-FU or 5-FU leucovorin. And cetuximab, bevacizumab, and all the other targeted agents do not add any benefit. So that's about 10 years of research on one slide. We give Folfox for 6 months, every 2 weeks, or 5-FU leucovorin once a week, or capecitabine 14 days on, 7 days off. This is the MOSAIC update. MOSAIC is the clinical trial that showed that Folfox was better than 5-FU and leucovorin. I will show you all the way on the right lower is the absolute benefit of an oxaliplatin-containing regimen, 1.6% overall survival. Yet this is what we get very excited about. It's very similar to data in the breast cancer population. It is an absolute survival benefit, and we strongly believe that this is something better than not just nothing, but also 5-FU and leucovorin. So this is what we tend to recommend for patients who are well enough to receive it and are willing to get a Metaport for the oxaliplatin infusion. What about the meta-analysis? That's kind of how we look at the broad picture. Adjuvant chemotherapy provides significant disease-free survival benefit, primarily by reducing the recurrence rate within the first 2 years of adjuvant therapy. There is some benefit in years 3 or 4, translating into the long-term overall survival benefit. This reflects the curative role of chemotherapy in the adjuvant setting. Honestly, we do help some people. After 5 years, recurrence rate in patients treated on clinical trials are low, 1.5% per year, but they're not zero. And after 8 years, they're minimal, 0.8% per year. Again, not zero. So don't say, well, there's no way this solitary thing in the liver could be a metastasis from your colon cancer 9 years ago. It's not likely, but it's still possible. Long-term follow-up for recurrence is of little value, especially if you look into how much radiation we deliver with the yearly CT scans. This benefit was primarily driven by patients with stage 3 as opposed to stage 2 disease. And as I mentioned to you previously, the BRAF V600E, the one that's found in the serrated adenoma mutation, was a marker of poor survival. So even with excellent surgery and excellent chemotherapy, if you have the BRAF mutation, it's not a good thing. So FDA approved FOLFOX4. There's modified FOLFOX6, there's FOLFOX6, FOLFOX7. The one we use most commonly is called modified FOLFOX6, but FOLFOX4 is the one that was used in the clinical trials for stage 3 disease only. So once it has moved to the lymph nodes, the main limitation for stage 2 clinical trials is that the absolute benefit expected is about half the benefit in stage 3. Twice as many patients are needed. Available studies are not powered to detect a statistically significant benefit in this subgroup of patients. In English, what this means is that there is a 20% benefit, a relative 20% benefit to chemotherapy after surgery. In stage 2 patients, the risk of recurrence is low enough that it's really hard to demonstrate a statistically significant overall survival benefit in patients who have a less than 50% chance of recurrent disease. So FOLFOX for stage 3 patients, yes. Some stage 2 patients as well, especially if they haven't had a superlative surgery. In stage 2, important to discuss potential risk-benefit with the patients. The things that we look at is the number of lymph node analyzed. We'd like to have 12 to 13 at least. Poor prognostic features, BRAF mutations, lymphovascular invasion, comorbidities, and anticipated life expectancy. If someone's going to die in a couple of years from a congestive heart failure, giving 6 months of chemotherapy is not in their best interest. Chemotherapy is not appropriate for all patients. I know you've never heard a medical oncologist say that, but it's true. Oncotype DX is a 12-gene recurrence score that may or may not be useful for some people. It's used for patients with stage 2 colorectal cancer who do not have mismatch repair protein deficient tumors, so those who don't have Lynch syndrome. It will tell you whether the risk of recurrence may justify 6 months of chemotherapy. Not everybody believes in it, but it has several clinical trials under its belt to show that it is a prognostic score. Adjuvant Online is very useful for patients who would like to know what they're buying for their chemotherapy. It will tell them the risk of recurrence based on their pathology, and they will show you graphically how the recurrence is reduced with chemotherapy. Metastatic disease. Unfortunately, this is what I do most of the time. For most patients, the treatment will be palliative, meaning not curative. I use palliative as the opposite of curative, not necessarily to help with symptoms. The treatment goals are to prolong overall survival and maintain quality of life. Live as long as possible with the best quality of life possible. Some patients with metastatic colorectal can be surgically cured of their disease, as you've heard already. And selected patients with initially unresectable liver metastases may become eligible for resection if the response to chemotherapy is sufficient. 3 months of chemotherapy, reassess, send them to a surgeon. These are the NCCN guidelines. NCCN, of course, is one of our Bibles for treatment. It's definitely the insurance company's Bible, so if it's not in there, that requires a lot of work on our part to tell them why we want to administer set chemotherapy in set setting. And why we do what we do is that with the more available agents, the overall survival of our patients has improved. The FOLFOX-IRI-BEV data that were published in the New England Journal of Medicine a year or so back, the arm with the FOLFOX-IRI-BEV had a 31-month median overall survival, which is almost unheard of a few years back. And here are the data. I won't bore you too much other than to say that in patients who have a high-risk tumor with many aggressive features, this is probably the most aggressive option for chemotherapy. I will draw your attention to the overall survival that was not statistically significant, but almost statistically significant. In our institution, we tend not to use it a lot, but the option is there for those people who want it. What about anti-angiogenesis? Trita Volkmann said we're going to be curing cancer because we're going to be cutting off the blood supply. Unfortunately, that didn't happen. I still have a job. And the anti-angiogenesis is, the idea is to reduce new blood vessel growth. The tumors cannot grow instead without developing a blood supply. You're supposed to starve the tumor of the nutrients by stopping its ability to get blood. But there are no criteria to find out who can actually benefit from the anti-angiogenic agents. Here is a table looking at anti-VEGF antibodies in the second-line setting, so patients who've had chemotherapy, usually with FOLFOX bevacizumab in the first-line setting. The three that are FDA approved, the bevacizumab, the zivaflibercept, and the ramucirumab, you can see the data are somewhat different, but also they were done at different points in time with different patient populations that need to be taken into account. You have options in the second line. The anti-EGFR, those are the cetuximab and the panitumumab. The receptor that's found on the surface of a tumor cell, it tells a cell to reproduce itself. Unfortunately, testing for EGFR on the surface of the cell is not very helpful. Comprehensive RAS testing is very important because that actually determines who's likely to respond or more likely not to respond if they have the mutation. And you need to do not just KRAS, but also NRAS, HRAS testing. So this is where next generation sequencing actually may be helpful. Patients with mutations do not respond to anti-EGFR antibodies. There are several trials showing the benefit of anti-EGFR antibodies. Some of these that I showed you on this slide actually are subgroup analysis. For example, in the CRYSTAL trial, the patients with wild-type KRAS had overall survival with cetuximab 23.5 versus 20 months. In the PRIME trial, the overall survival was also 24 versus 20 months. So panitumumab versus cetuximab, it's your choice. The main side effects are a pretty nifty rash. So you need to warn the patients that they can, even if they've never had acne before, they can get some pretty bad inflammatory rashes on this treatment, in addition to very long eyelashes. The newer drugs, the zivaflibercept, also known as Zaltrap, it's the VEGF trap. It's used with FOLFIRI, it's FDA approved. Here are the data, 13.5 versus 12.6 months in the second line setting. Very similar to the data with bevacizumab. Regorafenib or Stivarga is multi-targeted with looking at c-KIT, VEGFR2, BRAF. Unfortunately, even though I told you that BRAF, patients with BRAF mutations don't seem to benefit a lot, even though this targets a BRAF mutation, it has not been shown to be much more better than any other thing, even with the BRAF mutated tumors. The Lonsurf TAS-102 has been approved relatively recently. It's less toxic than regorafenib. There is an overall survival benefit. And the Cyramza or ramucirumab, very similar to the bevacizumab anti-VEGF, also with a survival benefit. This is the survival curves for Lonsurf. You will hear a lot of medical oncologists say Lonsurf really doesn't work. And really, if your expectation is for regorafenib or Lonsurf to shrink cancers and make tumors operable, yes, it does not work. However, these agents seem to slow down the cancer and allow patients to live with their cancer longer. So even though they're not cytotoxic chemotherapy in the traditional sense, patients seem to live longer if they're exposed to them. Immunotherapy, this is the last thing I promise. And the mutations in the mismatch repair protein, the ones in the Lynch syndrome are the ones that are targeted by the immunotherapy. And the immunotherapy looks at tumors with a lot of mutations. So it works particularly well in tumors with lots of mutations. Tumors that don't have a lot of mutations, meaning run-of-the-mill colorectal cancer, do not respond to immunotherapy. Pembrolizumab is the one that was studied in colorectal cancer. Here's an explanation. It's on your disc. And the patients who had mismatch repair protein deficient tumors, so those who had Lynch syndrome, had responses to pembrolizumab where the ones with the proficient colorectal cancers did not. So the immune-related objective response rate was 40%, while it was 0% for those patients who did not have the mismatch repair protein deficient. And here are the data showing that it's not just the colorectal cancer, but other tumors that have mismatch repair proteins that benefit from immunotherapy. And liver-directed therapy, I lied, but this, I'm not going to go through that because you've already heard that that liver-directed therapy includes surgery. And here are the data that I quote to my patients. 25% of patients may have prolonged disease-free survival, sometimes even cure from resection of the metastatic disease. You can also do radiofrequency ablation, chemoembolization, transarterial radioembolization as well, looking to decrease the tumor burden in patients who have liver-only metastatic disease. The rationale of the radioembolization is that you irradiate the tumors that are supplied by the arterial supply, which is the vast majority of tumors in the liver. And so the benefit is actually from radiation, not the embolization of the tumors. And the SURFLOC study, which was also reviewed before, shows that there is a progression-free survival in the liver if you combine first-line chemotherapy with radioembolization with yttrium-90. And here are the data for the liver-only metastases. There's a benefit in the liver, even in those patients who had extrahepatic metastatic disease as well. That was seen whether the patient received bevacizumab or not. The depth of response was much deeper for those patients who received radioembolization, suggesting that those are the ones who are likely to live longer with their metastatic disease. So systemic therapy remains the mainstay of metastatic colorectal cancer. Evidence-based treatment has been shown to extend overall survival. People live longer. Patients with treated metastatic colorectal cancer may live with their disease for years. They don't have to die in 6 months like they did 20 years ago. With judicious use of available treatment, quality as well as length of patient life continues to improve. Thank you for your attention. There's a question. That doesn't happen very often.
Well, thank you. I'm particularly keen to know what your ideas are about yogurt and epigenetics and eating food, or even the people who are on long-term antibiotics. Isn't there some relationship between germs and the gut?
So there's probably a lot of relationship. The problem is we haven't identified it yet. So what I tell patients who have cancer who come to see me is eat the best diet that you can based on the data that we have right now. Keep your bowels regular, don't overdo the sugar, the fat, and we'll know more as time goes on.
So there's no immediate explanation for how and why these things work? Not
at this point. Not an immediate, but again, one of the things we learn in medical school is that every 5 years we'll find that 50% of what we were taught was wrong. So just because I tell you that today doesn't necessarily mean...
Well, I'll come back in 5 years.
I have a question. I don't want to be too loud. So for the VEGF inhibitors, what makes you select one over the other?
One of the things is formulary. So we don't have, for example, zivaflibercept is not on our formulary because the powers that be said that the cost does not, the benefit is not worth the extra cost, that they looked at the data and there wasn't a benefit. However, there are some patients who have such rapidly progressive disease on FOLFOX-Bev that you want to change as many things as you can in the second-line setting, and they have a RAS mutation, so you may want to do FOLFIRI zivaflibercept or FOLFIRI ramucirumab in the second-line setting. But other than that, they do seem to be fairly similar in their activity. Of course, none of them have been compared head-to-head, so you have to look at very different patient populations in the studies that have been published.
I have a quick question as well regarding the BRAF mutation patients. Are you routinely testing patients for that, one? And two, in the stage 2 setting, are you using the BRAF mutation status in making your decisions regarding chemotherapy?
So the answer is yes, we do test routinely because we have clinical trials looking at BRAF mutations. Not everybody believes that patients with BRAF mutations do not respond to anti-epidermal growth factor receptors. There are some conflicting data. They're mostly retrospective data. So, but yes, we try to place those patients on clinical trials if at all possible. And in the stage 2 patients, not so much about deciding whether to go ahead with the chemotherapy or not, but we will use it to decide whether they're likely to have a Lynch syndrome that is passed on from a family member or a de novo or a non-germline mutation in their colorectal cancer, in their mismatch repair protein deficiency.
You again.